wanted to highlight some of the reasons I think TMS is of interest to integrative psychiatry. Very significant efficacy with difficult mood disorders. It's compatible with almost any treatment that one can imagine. Medications, supplements, other therapies, very few problems with interactions or complications involved with other treatments. And then in off-label applications of TMS, we'll talk about several of these: depression during pregnancy, postpartum depression, maintenance treatment for chronic depressive disorders, which is a very important area, bipolar depression, depressive disorders that are non-treatment resistant. Most of the FDA approval has focused on patients who have failed to respond to an adequate course of antidepressant therapies. And that's still mostly how TMS is used. At the end of the acute treatment phase, this 4 to 6 weeks of acute TMS, the average PHQ-9 had dropped from 18 to 8.8. And we're going to see what happened following those patients, then out for about a year. So these are people who had improved significantly. Their depression inventory had dropped by about 50% or more, and they maintained that response over the course of 12 months, essentially fully. And this has been our experience in our clinic as well, that many people who get a good acute response to TMS will maintain that response for months or years after their acute treatment. The risks of TMS are very low. Mild headache is the most common side effect. Usually, this is something that's noted in the first week of treatment and tends to diminish over the course of the first couple of weeks. Some patients will take Tylenol or ibuprofen before they'll come in for a treatment, but usually by the second or third week, they're no longer needing to do that. TMS has to be done with hearing protection. The coil makes a fairly loud clicking noise during the treatment. So patients are given ear protection to wear, ear plugs that they wear during their treatment. One thing that would be very valuable is if we could identify better likely non-responders. Even when TMS is well covered by insurance coverage, if somebody spends 6 weeks coming into our clinic daily for an hour, they've invested a lot of time. Many times they've invested a lot of money in copays. And if they're in the 1/3 non-responder group, that's painful. And so if we could use some kind of functional imaging to better advise patients on their likelihood of response, and there's some research going on this with some promising early results, but nothing that has been useful outside of a research setting quite yet.